Hello, my name is Andrew Jack from the Financial Times. It's a pleasure to welcome you to this plenary session of the conference entitled COVID-19, Major Disruptor, New Opportunities. You're going to be hearing from Maria van Kerkhove from the World Health Organization, Michael Osterholm from the University of Minnesota, Allan Maleche from Kenya, from civil society, and Madhukar from McGill University. And then join us for a short discussion with three of our four participants at the end of this session, with a focus on heeding the early lessons and preparing for the future.
Thank you for the opportunity to be with you today and to share with you a perspective on how did we get to the place we are today with COVID-19? Could we have been better prepared, and what must we do to be better prepared for the future? Let me make it very clear that we are not done with pandemics. As much as we're going to focus on COVID-19 today and understand its immediate threat, the world also presents many additional pandemic threats. Today, there are over 23 billion chickens on the face of the earth. And any one day, they make up over a third of all the avian species present. If you look at the issue of pigs, today we have over 390 million pigs on the face of the earth. All of these are necessary to feed the 8 billion people. But what that also has done is given us the most ideal genetic reassortment laboratory for influenza viruses. And the fact is that we will see additional influenza pandemics in the future. For all we know, they could be beginning right under our nose right now. This combination of risk factors for influenza, which to me still makes up the sense of the big one, this one is not, really is a challenge that we have to look forward to and we have to address. We no longer can hope that we'll be prepared for these experiences. So what have we learned with regard to COVID-19 that we can apply today to what it is we need to do to be prepared, and what can we learn for tomorrow? Well, to say we got caught flat-footed on COVID-19 is an understatement. At the time when it first emerged in the Wuhan area back in December, I think the world at that point was still quite asleep, not really recognizing what was happening, and it was only a limited number of individuals that really were paying attention to it. Our group began publishing about this the last week of December, when on social media, it became very clear to us that something unusual was happening in Wuhan. At first, I, like many others, probably thought, well, hopefully that's not flu. And when we found that influenza viruses were not common among the cases, there was a certain amount of relief, because then we thought, well, then it must be a coronavirus. But if it's a coronavirus, our mindset went immediately to SARS and MERS, severe acute respiratory distress syndrome, and Middle Eastern respiratory distress syndrome. And for both of those diseases, one, SARS, which we were able to effectively remove from the threat portfolio back in 2003 when it first emerged by actually identifying the animal reservoir in the food markets of the Guangdong province, eliminating those animals out of that market, and then understanding that humans were most infectious literally in the second week of their illness, not in the first days. And when we understood that, we could isolate patients who were contacts of individuals who had been infected and now were showing signs and symptoms themselves. And we could do it with enough timeliness that we could literally end SARS virus transmission. So that was a great success. 2003, we ended SARS. In 2012, when MERS emerged in the Arabian Peninsula, we weren't quite so successful. This time, the animal reservoir were camels. And no one was going to put down 1.7 million camels on the Arabian Peninsula. And so we've learned to live with MERS in the sense that, again, like SARS, the individuals who become infected from contact with the camels are most infectious in their second week of illness. And by early identification, we can isolate them and stop ongoing human-to-human transmission. Occasionally that fails, such as in 2015, when an individual who had been to the Arabian Peninsula came back to their home in Seoul, Korea, were hospitalized in Hospital A, where they, as a patient, infected another patient who, upon discharge from Hospital A, ended up at the Samsung Medical Center several days later, for which then he resulted in serving as the source for a major outbreak at Samsung Medical Center. I was involved with that investigation and can tell you the dynamics in a hospital setting for the virus transmission are remarkable. But again, because of the transmission being at the second week of illness, we were able to get that shut down and eliminated MERS from Korea. So based on that, when we first saw the emergence of a coronavirus in the Wuhan area, we had some relief, saying, well, we're going to have to find all these cases, get them isolated, get their contacts under surveillance. If they become ill, get them isolated, and we'll end this thing. But by the first week of January, it became clear to us through our social media contacts and actually individuals on the ground that we were talking to in the Wuhan area that this wasn't the case, that there appeared to be substantial asymptomatic transmission of the virus, and that in fact it was one not like flu, but that totally new kind of coronavirus epidemiology. By January 10th, we had the genetic sequences published on the virus. The epidemiology became increasingly clear as we started to see transmission in other countries of Southeast Asia. And we saw this uncontrolled transmission, many cases with likely asymptomatic transmission or early transmission into the illness by individuals in the Wuhan area. By January 20th, our group actually saw enough information to say this is going to be the next global pandemic. And we put out a statement as such on January 20th. The reason I tell you this story is something you may very well be familiar with, is the fact that we had early warning in January. If a little center like ours in the middle of nowhere, Minnesota, could determine that this was going to be the next pandemic, why did it take the world another month to 2 months to come to that same conclusion? The reason I bring that up is because due to our lack of creative imagination, we, in a sense, put ourselves into that position by not early recognition of what was happening. For any future pandemic, we now have to have a totally new index of suspicion. When we see events like we saw in Wuhan, the world has to be prepared to move much more quickly. Would we have ever stopped the pandemic coming out of Wuhan? I don't think so. I think once that virus was seated in that population in the month of December, it was already too late. And that is not easy for people to hear, but I believe it to be true. What we can do, however, is begin to prepare ourselves for limiting transmission in other locations. And as our Asian colleagues have taught us, when you can get on top of an emerging outbreak of a new pathogen, like even a respiratory transmitted coronavirus, you can do a lot to bring it under control when the entire house is not on fire. In other words, when it's a small brush fire, not a huge raging forest fire, your ability to do testing, contact tracing, and bringing the transmission to an end in a given area is actually much more likely. We didn't even have that possibility for much of the rest of the world with this coronavirus because we were so slow to first find the kind of diagnostic testing availability that we needed. And number two was the recognition that we could do something about it, like the Asian countries did. Today, here we sit in October 2020, and I can tell you with absolute certainty that we are going to continue for months and months to see this infection ravage the world. Right here in the United States, we have uncontrolled transmission in the upper Midwest part of the country, and we're going to continue to see that spread throughout the rest of the United States at a level higher than we've seen even in our peak back in July of this past year. We basically put the brakes on like many did in April of this year, but by the time we got to Memorial Day, our last weekend of May, we had had enough of this virus. Pandemic fatigue set in and we said, we're done, even though the virus wasn't done. In April of this past year, we were reporting 32,000 cases a day in the United States. By Memorial Day or late May, it was at 22,000. And then we let our foot off the brake completely. And at that point, you saw what happened in short order. By July, we were at 67,000 cases a day. And several locations in this country, notably the states of Georgia, Florida, Texas, Arizona, and California, were hot on fire. Well, then again, control measures came into place. People took distancing more seriously during that July peak, and case numbers began to come down through our Labor Day or the first week of September. Again, pandemic fatigue set in, and this time a new condition I call pandemic anger also became real. Pandemic anger is about a third of the population that believes that this pandemic's a hoax. They believe that it's all for politically motivated reasons that we keep bringing this front and center to destroy the economy, to basically hold people back from their civil rights for political reasons. When you put that all together, what we saw happen after that first weekend of September in the United States is remarkable. Between pandemic fatigue, pandemic anger, and the fact that we had students coming back to colleges and universities, which then caused a great deal of transmission in that group. And while they often don't contribute in a major way to the hospitalization rates in this country, they serve as an important source of virus transmission to those who are older, to those who are less capable of handling the infection, i.e. are more likely to have severe disease. We also then saw people just deciding, funerals, weddings, family reunions, city celebrations, restaurants and bars. All these things just became the norm again. And with that, we saw substantial transmission, and such that in the United States today, we are now, just in 1 month, we're back from 32,000 cases a day to back up into the 50,000s per day. We are seeing the upper Midwest with as much infection transmission as we saw in the earlier summer months that in those other states I mentioned. And we have most of the United States now seeing substantial increases, well into 40 states showing substantial increases. This does not look good. Vaccines will not save us anytime soon. At best, the impact that they might have is going to be sometime early to mid next year. So what does this all mean in terms of Europe? Europe actually, like us in April, had that house on fire moments, the Lombardy region of Italy, Spain, England. I can go through the laundry list, you know it well. And at that time, Europe as a whole did a remarkable job of, in a sense, locking down, that horrible term that we all hate to use because it means so many different things to different people. But it was all about distancing. It was all about mitigating this transmission risk by just keeping our distance and wearing masks that will have some role in reducing transmission. But again, distancing was most important. That meant bars and restaurants, which were a very important source of transmission, needed to curtail their hours or even be closed. Europe did what we didn't do. They stayed locked down in that sense through the early summer months that when we didn't do it. And realizing that this was not going to be a long-term solution, but one that hopefully would last until we had vaccine, how do we then let that break up? How do we bring back society to a level where activity can be increased, which, by the way, the Europeans did on a whole. If you look at the GDP, they suffered just like the United States did in April of this past year. But by midsummer, they actually had recovered a great deal of the loss when the United States hadn't. People were willing to go back into public places. They were not fearful. But then what happened is really the release, I believed, happened at an accelerated rate beyond what could actually be able to be used to prevent transmission. And now we're seeing in this October time period, the major increases in cases again in Europe. Now, the good news is they're still much, much lower than we've seen in the United States. And so from that perspective, Europe still has a chance, I think, to drive cases down with moderate levels of some type of distancing restrictions and business-related closures. Now, in the United States, we have urged all along that those businesses and individuals who suffer because of the need to close down or create distancing should be financially cared for. And in that manner, they're contributing to the common good of the public. In some countries that's happening, in many it's not. That's a reason why so many are against these kind of closures. Now, I'll tell you right now that if you don't close, if you don't try to do something, the cases will only continue to get worse, and then the public really won't come into public spaces. They won't be there. It won't be government restricting people's movements. They'll restrict themselves. And at that point, you'll see tremendous impact on your society and your economies. So we're at a very pivotal time. In this particular pandemic, we're at a point where we have to ask ourselves, what are our next steps? Will vaccines save us? Most of us don't think so. If we get a vaccine that's even 50% protective and 50% of the population takes it, that'd be a great start. The problem is that's only 25% of the population that wouldn't be then protected. And if you add on the 10% of the population that's likely had disease by now, that's only 35% of the total population. Hardly enough to get us to a herd immunity sense of 50 to 70%. So we have to understand we're going to be in this situation for a while. Vaccines will hopefully improve. More people will be willing to take vaccines. We hope we will have durable immunity, something that at this point is still a challenge, a question: how well will these vaccines work over time? How safe will they be? And this is all information that we have to take back and store away in our files for what do we do tomorrow. If we had a large influenza pandemic today, like the 1918 pandemic, we wouldn't be much better prepared. It would take us months to get us influenza vaccines. As we saw in 2009 with H1N1 there, a more milder pandemic, that most of the vaccines that arrived were far too late, and that the questionable protection was a challenge, with the vaccines at best giving us 45 to 50% protection. So what this all should say to us is the world can't continue to suffer these kinds of events. We must do whatever we can, whatever we need to do to be better prepared. For the future, we need to invest in a whole entire new concept of vaccine platforms or ways to deliver vaccines, that regardless of what the new virus or bacteria happens to be, we can quickly bring those vaccines forward without having to spend months and months of research. We need to help the public understand that supply chains on a global basis are important. When we can't get many of the goods we need today because one part of the world is, in a sense, a house on fire, what does that mean for how we do business? What if those are life-saving critical drugs we need, we can't get, which is actually what's happening right now. We also have to understand, how do we communicate to people? We have a very divided world right now. Our country is right at the center of some of that great debate. But the point is, we will have pandemics again when it's never convenient. And we have to understand, how do we best communicate with the public? How do we bring consensus? How do we bring support? And how do we bring a vision for how to get through a pandemic? These are all lessons we're learning right now, and we must never forget them. I feel like in some ways we actually are on a 727 jetliner that's going down, and there's no one on it except for 1,000 black boxes. And when those black boxes hit the ground, we need to go back and look at every one of them and understand what could have and should have we learned from that experience so that we don't have to go through the same thing again. So I leave you with the sense that we are in a very dire position today. We have to do whatever we can to help us get through this pandemic, with understanding that short-term goals will be to prevent as many infections as possible until we get to a vaccine, then to maximize on vaccine, both in terms of its effectiveness, safety, and availability, and then make certain that we are much better prepared for the next pandemic, because it will happen. Thank you.
Thank you for having me. It's a pleasure to address you all today, especially as we are marking the 100th anniversary of the Union this year. We are now in the 10th month of the COVID-19 outbreak, dealing with a new virus that has affected the lives of everyone on this planet. We have taken this virus seriously since day one, and WHO has worked around the clock to support countries to prepare and to respond to it. Our first set of guidance, based on our previous experience with respiratory pathogens and the knowledge we had, was issued on the 10th, 11th, and 12th of January, 10 days after learning about this new virus. Within days after the full genome sequence was shared by China, and together with our technical partners, we published the first protocol for developing a PCR test. At the same time, we worked to expand testing capacity around the world, leveraging existing infrastructure and building capacity where it was lacking. Since then, we have expanded and updated our guidance as the pandemic evolved and as the need for the response expanded and as the science grew. We have worked hard with partners to address the global supply chain challenges and ensure supply of essential equipment, medicines, tests to countries around the globe. We continue to coordinate the international and global scientific community to harness robust science, to develop guidance and advice, to deliver the trainings and technical support, PPE, tests, treatments, and eventually vaccines around the world. While we are responding to COVID-19, WHO is also working with countries to ensure other essential health services continue undisrupted. At this pivotal moment, with COVID-19 still spreading, many people who need counseling for tobacco cessation and treatment for TB, cancer, diabetes, asthma, and COPD are not receiving the health services and medicines they need. A WHO survey from August found that almost every country had experienced a disruption in essential services. 70% of countries reported disruption of services for non-communicable diseases, 55% for cancer diagnosis and treatment. Over 45% of countries had disrupted their services for diabetes and asthma. And 42% of countries reported disruption of TB detection and for TB treatment. All this implies that more people may suffer and die from other diseases that in many cases are treatable and curable. A modeling study done by WHO with partners showed that even a partial 25% disruption in TB detection and treatment could lead to 13% more deaths from TB this year. This would be and is unacceptable. We need to act with urgency to reinforce health services and increase investments in resilient public health systems worldwide, even in the midst of a pandemic. In fact, one of the lessons of this pandemic for us has been that investment in health systems and preparedness pays off. Countries that have done well in dealing with this pandemic have done precisely that. When this virus hit us, many countries were able to leverage existing capacities, be it the influenza surveillance systems, the molecular diagnostic testing capacities of TB programs, to respond more effectively to COVID-19. Countries have used their experience with community health workers, strong engagement with populations, clear, open, and honest communication, a strong workforce for contact tracing, to fight other infectious diseases and identify and to fight this outbreak. These past investments have been critical in countries' successes responding to COVID-19. Another lesson has been the resilience we have shown in the face of this pandemic. The last months have required us to make many changes in how we interact with each other. Many of us has changed our behaviors and are keeping a distance, wearing a mask when we cannot keep a distance, cleaning our hands regularly. In the same manner, health systems too have had to be agile and resilient. The use of digital technologies has increased, and programs like the ones for TV have adapted, and small innovations like delivering medicines closer to patients. These small innovations can make all the difference and save lives. We have to keep people at the center of the care we deliver. This has long been WHO's vision, and in this pandemic has underscored its importance. It has taught us that there is no substitute for strong public health systems, be it for COVID-19, asthma, COPD, cancer, or TB. People's lives depend on it. This urgency continues to motivate WHO's work with countries, even as we push forward the global search for a COVID-19 vaccine. Thank you.
Hi, thank you for the opportunity to present in this plenary session. Next slide. I have no conflicts of interest to report. Next. So I think in the last 6 to 8 months, we have seen an absolute devastating impact of the pandemic itself in terms of lives lost, but there is also the collateral damage that the pandemic and the disruption of health services and lockdowns are creating across all areas of global health. I think we are already seeing increase in malaria mortality, a prediction of increase in HIV mortality because antiretroviral treatment is not reaching people, millions of babies who've not been vaccinated, disruption to non-communicable diseases care, and the greatest recession since World War II. All of this makes for a very, very sad story. I mean, the highlight of this is what I read recently, 25 years of progress rolled back in 25 weeks. It's just simply devastating. Next slide. Among all of these conditions, I think the impact on TB has been incredible. This is a large survey by more than 10 TB civil society organizations that was released recently on an impact of the pandemic from a community perspective with more than 1,000 survey responses from around the world. Next slide. And I think what we are seeing in this particular survey is incredible disruption on the ground on all aspects of tuberculosis. For example, people with TB symptoms are simply not seeking care. They are afraid to seek care, or when they do seek care, the clinics are shut or the private facilities are not working to their optimal potential. We're seeing a massive decline in TB case notification. Amount of TB tests being done has dramatically gone down. In addition, TB personnel working in TB clinics have been diverted to work on COVID. TB wards, isolation wards, have been converted into COVID wards. And there's a looming anxiety about TB funding being diverted to COVID and a risk of TB products such as TB tests and TB medicines getting stocked out because many of these are manufactured in places like India, which are very badly impacted by this pandemic. Next slide. And so the Global TB report released this year, although the numbers have not changed much since the last year, 10 million TB cases and about 1.4 million TB deaths, it's really alarming to see the steep decline in TB notifications just in the first 6 months of this year. And data shows that it even persists and continues into the second half of this year, and up to 30 to 50% decline in notification across many countries. In this slide, you see India, Indonesia, Philippines, and South Africa as merely examples. The TB report provides data for many other countries as well. So pretty much every high burden country is suffering right now in terms of a big decline in TB case notification. Next slide. And I think the impact of all of this, when we are not picking up TB and helping TB patients get on TB treatment, the consequences could be disastrous for them in terms of delayed diagnosis, more severe disease, greater risk of transmission within the households, and of course, higher risk of mortality. The Stop TB Partnership, along with many others, did a modeling study which projected that we may have up to 6 million additional people developing TB in the next 5 years, and almost 1.5 million additional TB deaths, depending on the duration of the lockdown and how damaging it could be. The TB report by WHO this month suggests that we could have as many as 400,000 additional TB deaths just during this calendar year if up to 25 to 50% of TB patients are missed in this crisis, as the notification declines do suggest that many people have been missed. This is a massive setback for all of us in TB, and we must do the damage control to prevent this level of devastation. And that means resuming TB care services, making sure we catch up on all the people who've been missed in the last 6 to 8 months and put them on treatment and diagnose them again. Next slide, please. And here, as much as this is such a doom and gloom scenario for TB, and it does depress me a lot even thinking about it, there are people who are increasingly asking the question, okay, so COVID, everybody's COVIDized. COVID is getting huge amounts of money and support and R&D and innovation. Every country is responding to COVID in a big way, almost at the cost of everything else. Is there anything from the COVID innovation space, from the COVID systems that have been put together in the last 6 to 8 months that we can repurpose and leverage to fight TB? And in the early days, I think in the TB community said, we have a lot to offer to the fight against COVID. But I think now we should ask the reverse question as well. What are the COVID innovations and systems that we can repurpose and fight TB? Next slide. So here are some thoughts of what we could be doing to do damage control and to kind of use the opportunities that COVID pandemic is giving us right now. I think all of us have apps on our phone now. We have COVID screening apps, we have COVID tracking apps, we have real-time dashboards. All of us know how widespread the pandemic is. We even have detailed data by city, by country, by district. Why can we not have something similar for TB? Why can we not have more real-time information on how much TB there is and where TB is happening? Why do we have to wait every once in a year to see TB statistics? And these apps could also be used to educate people that cough could also be TB, that anyone coughing for more than 2 weeks should seek care and find a way to link them to the nearest testing facility. Next slide. The next thing I would like to talk about is the incredible innovation that's happening around the diagnostic space right now. We know, for example, there are point-of-care molecular tests that can be successfully deployed for both TB as well as COVID-19. We should insist that whenever these molecular tools are being used for COVID, that they also be used to test people with suspected TB, or come up with bidirectional screening strategy that anyone with COVID should also be tested for TB and vice versa. And there are good technologies from India and the Gene Expert technology as well that can be repurposed for that. Digital chest X-rays are already an established triage test for TB with artificial intelligence-based software. And such software have also been developed for COVID-19. So we should find a way to screen for both respiratory infections at the same time. Dramatic innovations are being made in the sample collection and transportation area. Much simpler samples than in the nasopharyngeal aspirate are being tried out. Why could we not try them out for TB as well? And why can we not have drive-by sample collection spots, a home-based collection of specimens, so that people will not have to struggle to go out and wait in line for days before they get tested for TB, as it is right now. Next slide. In terms of treatment support, I think telemedicine's shining day has arrived. We are learning that not everybody needs to lose a day's worth of work and show up at the clinic, that we can get a lot done through telemedicine, teleconsults, education or reminders through WhatsApp. Call centers can be used. There are a whole array of digital adherence technologies that can be repurposed for COVID and TB, such as Smart Pill Box, Video DOT, 99 Dots, and even using treatment supporters and DOT supporters to assist people with TB and COVID. Next slide. I think here we are talking about people and systems that are now actively in place to fight COVID. For example, we know that there are e-pharmacies that can deliver medicines, TB medicines or COVID medicines to homes. We have contract tracers explicitly working on COVID, and we know contact tracing is a critical part of TB as well. We have DOTS providers and community health workers. All of them are available and doing COVID work. We must make sure that they also look after TB during this crisis. In other words, the human resources should not be just for TB. It should also be used for tuberculosis. Next slide. And then we have never seen anything like this before, where so many governments are now offering paid sick leave to people. They're covering the entire duration of illness or the amount of time people are quarantined. We should absolutely insist that something similar be done for everyone with TB. They must get paid sick leave for as long as it takes for them to get back and recover and go back to work. Masking of people with cough can only help TB, and the more widespread masking is, the less likely we will see community transmission. And we must make sure healthcare workers have PPE for TB as well, because all these years we've ignored occupational TB, which is a well-known hazard, and we simply haven't given protective equipment to healthcare workers. Hopefully, COVID will now make it clear that healthcare workers also need to be protected. And just this mass behavior change we have seen with COVID, it also is possible for TB, but we've got to use this momentum to make it work. Next slide. And I want to kind of talk a little bit about the R&D. I mean, this is a staggering amount of R&D and investment in COVID, all within 8 months. We have dozens of COVID vaccine candidates in the pipeline, dozens of COVID treatments in the pipeline. More than $160 billion, according to an estimate, have been invested in grants and program announcements around COVID-19. More than 50,000 publications on COVID-19 have appeared in the last 6 to 8 months. I mean, we are still using a 100-year-old vaccine for TB. The amount of investments that have gone in COVID vaccines in 6 to 8 months exceeds all the investments ever made on TB vaccine in the history of humanity. How is this acceptable, given the death toll that TB has cost in the last several years? We must ensure that these R&D investments are not wasted, and that TB also deserves R&D investments and funding and research support. Next slide, please. I want to end with this piece that I wrote about the syndemic of COVID-19 and TB. We should see it as a syndemic. These are epidemics that feed off each other and affect mostly the same vulnerable population. They're both airborne, they're both respiratory, and they can both be confused with one another. So finding a way to leverage and repurpose everything we have for COVID to fight TB and vice versa must be a critical part of our strategy to get out of this devastating situation we are in. And I want to end by quoting a friend and inspiring colleague, Jen Furin, who said to me that while the research predicts doom and gloom for TB, if we are smart, persistent, and creative in adapting some of COVID-19 successes, this could actually become our finest hour. I can only hope that this dream or vision comes true, that we as a TB community will make sure TB does not completely fall off the radar. In fact, we come out stronger and build back better than what we had in the past. Thank you very much.
Thank you for the opportunity to speak at the 51st Union World Conference on Lung Health. My name is Allan Maleche. I work with an organization called Kelin, which is based in Nairobi, that focuses on health and human rights. This morning, I will be speaking to you about an important topic on COVID-19 and what are the human rights lessons we have learned for reflection for now and, of course, for the future. My presentation will cover 4 key areas, giving a background to how COVID-19 has linked up with the issue of TB, the human rights concerns that have come up generally as a result of the responses put in place by various governments across the world to address COVID, and then comparison of some of the approaches used in the response to address the spread of COVID vis-a-vis the approaches that have been used with dealing with the TB response. Then we'll conclude with the lessons learned and see what then can be our take home in terms of ensuring we keep fostering a human rights approach to the way we deal with any form of pandemic. I look forward to your great contribution to this conversation. But for now, let's start off by talking about the virus, the coronavirus that struck the world sometime in March this year, affecting everyone in every place of their different parts of the world. And from what we've learned from the spread of the coronavirus and its impact, we know that it is the marginalized communities that have been hit both medically and socioeconomically. And by marginalized, we're talking about those who are poor, those who already have underlying conditions, including TB or HIV or diabetes. We're talking about those who have no access to clean running water. We're talking about those who have no access to good housing and good ventilation. So what COVID has shown across the board is that many of the marginalized and already vulnerable communities have been the hardest hit, both on the medical and the socioeconomical part. And I think what the pandemic, the COVID-19 pandemic has done is to further expose the social disparities between communities, where the rich have been able to get access to treatment, they have been able to have access to clean running water and good sanitation, whereas the poor have continued to suffer in grave circumstances where they are unable to practice social distancing. And so, as I said, this presentation will highlight some of the human rights lessons learned, especially from the TB response, and reflect on the recommendations for the future. Next slide, please. So what have been the human rights concerns in COVID-19 response? I think generally from the experience in Kenya and experience in other East African partners, and generally from what we have read from various publications, is that many countries adopted a medical approach and a top-down approach in addressing the COVID response. And for that particular reason, they did not put into account the needs of vulnerable groups. It was more of a position of keep physical distance or social distancing, as they would call it, ensure you wash your hands, ensure you wear a mask, keep into regard the regulations that have been set into place, but nothing was taken into account to look at the fact that if I could not afford a mask, what would happen to me? If I had an underlying condition, what circumstances should be taken into account? If I was not able to access soap and clean running water, what should be done to be able to take care of my circumstances? So the measures that were put in place were largely copy and pasting the guidelines put by WHO or other players without contextualizing them within the context of the vulnerable communities. We also saw increased human rights violation during the rollout of the COVID-19 responses, partly in countries where there were lockdowns, there were restrictions on movements, there were curfews in place, There was a lot of police brutality. There was arbitrary arrests. And again, access to justice was limited because of the fact that in certain areas, access to the court was not extremely easy. We saw the rushed publication of regulations and rules that were put into place without proper consultation and eventually without public participation. And again, some of these rules and regulations had got very punitive approaches that did not do great justice in terms of promoting public health, but instead promoting a criminal approach to enforcing public health measures. The rights that we saw impacted across the board included the freedom of movement, the right to the highest attainable standard of health, dignity, right to information, social protection, the right to work. There are people who lost jobs, the right to liberty. There are people who lost their liberty. Some people were unable to access justice when they faced human rights violations, and some were unable to get a fair trial. And in some instances, especially in the context of Kenya, we saw a lot of inhumane treatment in the way certain practices of mandatory isolation and quarantine were carried out. So we just want to quickly look at the comparison that comes up with regards to issues relating to TB. As we all know, just like the TB response, we began from a very heavy medical perspective, one that did not center around the approach that considers what is it that the person who's affected TB needs and how do we structure something around it. Instead, we just took a medical approach in the TB response in terms of saying, here are the antibiotics, we need to get people to take them, irrespective of the side effects, we need to test them, and we need to treat them, and we need to isolate them where they're infectious. And this is the same approach that many of the governments took into account when taking the COVID response. They failed to take into account a holistic perspective that though the pandemic was medically related, what were some of the socioeconomic effects of that particular pandemic and how could they address them? They began more with test, treat, or rather test, isolate, and try to figure out how to manage people with their symptoms and their conditions. And so you'll see from different parts of the world that by failing to adopt a rights-based approach, human rights were violated. I've already talked about in the context of Kenya and in many other countries where they stopped flights from coming in, any person who came back home was required to quarantine. And in certain countries, they made quarantine to be mandatory at one person's individual's cost. And again, they made it in certain stations that were not hygienic and would also serve as spread of COVID to happen in those areas. Some people were held up in school hostels. Some people were held up in crowded spaces, and this again posed the risk of further spreading the epidemic. And we've seen this before also with the TB response, where people who've interrupted their treatment end up being taken to prison or to concentrated camps where they're supposed to then be able to address that. We saw the fact that there was intimidation of the right to information. Journalists were not able to get all the information that they needed to be able to hold governments accountable with regards to the response. We noted that there was always an excuse in terms of trying to contain the viruses that justified the use of police brutality. In Kenya, we have many recorded cases of police brutality. We even have a fatality of a person who was shot because they were not wearing a mask. And we have a situation where the public health system then abdicated their role to the justice system or the criminal law system, which was extremely counterproductive in enforcing social distancing, in ensuring people are wearing masks, and in ensuring that people were maintaining high levels of hygiene. So we see a trajectory where governments took a medical response as opposed to looking at a holistic response and took a top-down approach where the central government kept telling everyone, this is what needs to be done without getting the buy-in of the community. And this is something that the TB response has quickly changed their mind about and has begun embracing a people-centered approach, a rights-based approach, and ensuring that the needs of people are taken into account and that you have the buy-in of people. So as we go forward, we hope that some of the lessons that could be learned is that it's important to remember that in all pandemic settings, you're still dealing with human beings. And what is important is that you must put human beings at the center of the response. This continues to be ignored. It was ignored at the beginning of HIV, it was ignored at the beginning of TB, it was ignored at the beginning of Ebola, and again, it was ignored at the beginning of COVID. We would think that because we have gone through various pandemics, that COVID would have been better in terms of how we deal with the issues. And so we must remember that when we ignore putting human rights and people at the center of the response, that then becomes problematic. Secondly, when we use criminal sanctions to enforce public health measures, we have lost the war in persuading the community. We should always begin by explaining, understanding the challenges that may make it difficult for one to comply with the regulations, making adaptations before we take the enforcement route. But what we've seen in many countries is actually the enforcement route. And I think the other lesson learned is that let us not use stigmatizing language, because what we then discovered is that people who had TB, people who had any respiratory problem ended up being reported as possible COVID patients. And actually, in the case of Kenya, we actually had a gentleman who had an asthma attack and eventually found himself in a COVID isolation place trying to get managed for COVID, yet he only had a respiratory infection. And I think the last lesson, and most importantly, governments have received significant amount of resources to be able to address the COVID-19 pandemic. I think what is important and what has not clearly happened is to figure out how are they utilizing those resources to be able to strengthen their public health system and approaches. It's not only about infrastructure, but it involves investing in healthcare workers, training them, paying them well, and ensuring that they have got good working environments to be able to serve the broader public. And what's more importantly is that we should not only concentrate our efforts on COVID and forget about HIV, forget about TB, or forget about reproductive health, because that's what has actually happened with the curfews. People are told to stay at home, and so people ended up not going to hospitals to be able to do their routine checkups and take issues forward. I want to conclude by saying that it is extremely important for us to appreciate the fact that whenever there is a rights-based approach involved in dealing with any health issues, your chances of succeeding are high. We did have this rights-based approach employed in New Zealand, and we've actually seen the turnaround rate of them managing and bending the curve being extremely good. So I think the lesson for many people to learn from here is that a rights-based approach is the way to go in terms of dealing with pandemics, and this is what we must continue to adopt both for TB, both for COVID, and any other future pandemic that is going to affect us as human beings. Thank you very much for listening to me. I look forward to the discussion and the questions from colleagues. Merci.
My name's Andrew Jack from the Financial Times, and it's a pleasure now to follow up the presentations from our speakers with some brief discussion. The focus is heeding the early lessons and preparing for the future post-COVID-19. So we've heard already from Maria van Kerkhove from the WHO, who unfortunately can't be with us for the discussion. We're going to hear from Michael Osterholm from the University of Minnesota, Allan Maleche from Kenya, and Madhukar from McGill University. Michael, let me just start briefly with you. So you gave a great overview of reflections on past pandemics. Honing it down a little bit then, so what do you think are the couple of key lessons that we have learnt or that are different compared to past pandemics?
One of the things that is going to be a very critical distinction between this pandemic and the ones that we're most familiar with, namely that of influenza-based respiratory transmitted pathogens, is the fact that we don't know when this one might end. And if you look at the previous 10 influenza pandemics, usually within 2 years, the population had either been infected and developed immunity, or in the later ones in the 20th century, vaccine played some role. With this one, because of the questions about durable immunity and whether or not being vaccinated or becoming infected and developing immunity results in long-term immunity, means that we're going to have to consider the possibility that we may be in this situation for quite some time to come.
And do you see any particular connections or input from what's happened with TB and its intersection with COVID, things that we've learned from or barriers to progress?
Well, I think one of the things that TB really illustrates falls really square in the comments I just made, is that, you know, we never get rid of TB in the way that we want to eradicate it from the world. We're constantly dealing with the challenges of TB on a daily basis. And I think that we've learned the real issues that come to play if we let down our guard with TB transmission, if our programs are somehow cut short or inadequately funded, what that means in given countries. And I think that this is going to be very similar to what we're going to see with this coronavirus, is the fact that we are likely going to have ongoing public health programs. We may very well be talking one day about booster doses for vaccine, but many of the long-term consequences and our need to continue to make this a high public health priority, just like we should and must do with TB, I think is going to be a potential reality.
So, Allan, you talked very powerfully in your presentation about the issues of discrimination and how, indeed, those who were most disadvantaged, suffered more, really, in the current crisis. Again, how many parallels do you see between perhaps the resonance from what's long been the case for those with TB and the wider population who's now been experiencing some of these same pressures and tensions with COVID?
Thanks for that. And I think for me, as I mentioned earlier in my presentation, COVID has continued to worsen the situation for those who are more vulnerable. And it has actually brought into light the disparities that exist in our healthcare system, but also in our socioeconomic system. Those who have no access to good hygiene, access to good water, access to good healthcare are the ones who have suffered most. And so in that sense, I think what we need to learn and take the momentum in this particular situation is to see the funds we are getting to address issues relating to COVID. How well are we broadening to use those funds to address the inequalities that have been long outstanding? How well are our governments and leaders thinking through that? Now it's time to fix my health system. Now it's time to fix my social system. Now it's time for me to think through how do I address this vulnerability so that it does not become a problem. So I see it as an opportunity, but unfortunately, I don't see many countries executing it in that perspective. It's more, let me flatten the curve for COVID and then I move on to my normal life. But this should be a turning moment to say, even as I'm flattening the curve around COVID, the bad things COVID has exposed about my health system, about my social system, as a government, as a leader, what am I doing about it? Over.
And we'll talk a little bit in a minute about the future, but what seems pretty clear is the sort of level of double discrimination and double burden that we've seen on people with TB, now also affected by COVID. Is that right? Or have you seen any bright spots relative to that general pressure?
Well, I would say it's a double burden to the extent that, given that COVID has an element of affecting the respiratory system, the stigma people faced with TB in terms of coughing, in terms of weight loss, I think has manifested itself. Because when we had the outbreak of the coronavirus, now coughing is almost a taboo. And we have actually experienced in Kenya where people have been reported to the agencies where they have asthma attacks or they have breathing problems, and people say, oops, my neighbor has COVID, because there's a hotline you're given and you're saying, if you see your neighbor has breathing problems. So the effect of that is that people who may have had TB infection are fearing to be very public about their symptoms, their signs, because it could be conflated with COVID. And that means less people have been showing up to healthcare facilities. And in the case of Kenya, the one healthcare facility in the capital, Nairobi, that was designated towards respiratory diseases, and particularly TB, was actually set up as a COVID center. And so everyone knew that's not the place to go when you're sick. And so again, that has really affected the uptake of people and doing a lot of injustice to the fact that we've been spreading the message the moment you're coughing, the moment you're having sleepless nights, go to the clinic. But now we have curfews and you're told stay home, stay at home, don't go out. So it's been quite a challenge for people who actually have TB, those who may have been infected during the period, in terms of the continued chain of access to healthcare to reduce the number of cases. And I guess what you've seen from many studies and from many people is that then we're losing the gains we have made in the TB response. And that's how the double discrimination is coming in, not only on the people's vulnerability, but how we are managing COVID and the messaging that is affecting people who have TB and those who are likely to get TB in the process. Over.
Sure. So Madhu, you talked very articulately about a number of the, as it were, perhaps the experiences of TB that have been useful and important in the current COVID situation, including the development of newer diagnostics. But how significant has that really been? You know, how far has TB almost been able to help mainstream and share tools that are making a difference in terms of controlling the wider current pandemic?
Thank you, Andrew. I mean, I don't think the TB field has ever seen a bigger stressor or a shock than this pandemic. The fact that we are seeing decades worth of progress being pushed back is quite scary to our system. I can see that in the early days of the pandemic, more around March, April, all of us in the TB field used to say, oh, TB has a lot to contribute in this fight against COVID because we understand respiratory infections, we do contact tracing, we have sputum-based diagnostics, we have isolation rooms. But now I'm starting to think that we should be thinking in the reverse direction as well. What are the COVID-related technologies and innovations and systems and money that is flowing into COVID can be used to kind of do damage control around TB? Because look at the investment in COVID. It's just mind-boggling. I just saw somewhere $160 billion worth of investments, 50,000 publications in 8 months, dozens of vaccine candidates. We're still using BCG, which dates back to 1921, Andrew. Nobody invested in a better TB vaccine for decades. And here we are, like dozens of COVID vaccine candidates. Makes me very cynical sometimes that unless rich people in high-income countries are threatened, there will be no real progress in TB because TB is this poor man's disease that is somewhere else and it doesn't affect us and therefore that we won't invest in it. It's really sad that TB has never had that level of investment for hundreds of years. And in 8 months or 9 months, we will have dozens of COVID vaccines in phase 3. How is that even possible? I'm not saying we shouldn't invest in COVID. I'm just saying let's not lose all of the COVID investments and technologies, from apps to teleconsultations to better, faster ways of getting through regulatory approvals and trials to collaborative research. Let's make sure TB is also sandwiched in there so that we can do some damage control around TB.
And you talked about in your presentation the potential of this being the finest hour. I mean, what's your best hope that, given, as you say, of course, TB, as we know, is typically marginalized, discriminated, it's a stigmatized disease still. What might be the best hope in terms of driving the best momentum that's happened around COVID back into the field of TB?
I think I want to echo what Allan said. The biggest anxiety I think I have, and I think many of us have, is all countries are temporarily laser focused on health, right? Health-related investments. The minute this pandemic quells, all politicians will drop health and go back to whatever health they were doing before. In other words, if we don't use this crisis and invest in universal health coverage as a long-standing solution for better pandemic preparedness and for everything else that we've learned, then TB will suffer because TB desperately needs the protection of UHC because TB affects the poorest of the poor in every country. And therefore, my biggest dream would be UHC gets front and center on the political agenda for our country's leaders to have learned this hard lesson that health is wealth and wealth is health, right? You cannot have one and not have the other. I don't think there is a better demonstration of the importance of health than in the history of humanity than this year. But will our politicians learn it? I fear that they may not.
And Michael, what would be your greatest hope that really potentially could come from the COVID situation or pandemics more generally and improve the situation for TB prevention and treatment going forwards?
Well, I think you just heard one of the most articulate arguments you could ever imagine. Thank you for that. I think it was very well done. I do believe, because COVID will not end overnight, it's not going to suddenly be done, that we do have the attention of leaders from government, from the financial worlds, et cetera. We have to help them understand we can continue just to deal with COVID, or we can actually deal with the entire public health array of challenges, which in the end will be what will make us a much better prepared world for the next pandemic, as well as dealing with the cost of everyday current challenges like TB. So I think that I just echo the comments I just heard.
And Allan, you're finally your greatest hope for optimism, the thing that perhaps has the biggest potential chance of ensuring that at least some of the benefits of this great attention and focus and resources around COVID could feed back into TB.
I think based on the two colleagues, Madhu and Mike, I think the importance is that are we able to realize that we have to address health issues from a holistic approach? Will our leaders then eventually appreciate why clean water, good housing, good roads, good education, and good healthcare is important to put as a priority? And how are we going to draw from the lessons from HIV, TB, Ebola to be able to come up with stronger health systems? I couldn't agree more with Mike and Madhu that yes, UHC, the broader public health perspectives, but this is eventually now where the rubber hits the roads. All those targets we signed at the high-level meeting for UHC or for TB or for HIV, this is the time for leaders to walk the talk. And definitely as civil society, we continue to play the role to say we have to push and use this particular momentum to make health centers. So the future and the hope is governments realize we must make these crucial investments in socioeconomic rights.
So Allan, Madhu, Mike, sorry we don't have more time, but thanks for your insights and good luck in your work. And let's hope that TB can get a greater voice in the efforts going forwards. Thank you both.
Thank you.
Wonderful job.